Okay. We still have a few minutes. Let's wait for an additional minute or two, and then we'll start. But yeah, this is the QR code to the Socrative. We will be having quite a few. Um, so yeah, feel free to join, and soon we will start and we'll go through the GI pathology of LabMed. Hopefully you're doing okay. It's not far until Christmas, so happy days. If anybody wants to turn their camera on, much appreciated, but I understand if not. Right, so how about we start? So, hello to everyone I have on call. My name is Kasper. I'm a year 5 student, and I will talk to you about the GI pathology. Hopefully, you can hear me okay. If anybody just could tell me that they can see the slides and hear what I'm talking about. Amazing. Right, so it will be a whiz through. If at any point you'd like some further explanation or ask questions, just let me know. And yeah, I guess let's start. So, this is the syllabus for the GI pathology. As you can see, there is a lot of it. I found it quite overwhelming at the beginning. However, a lot of those things do share common principles. We'll try to walk you through it. We will try to talk through the key nuggets. Yep, key nuggets of wisdom. And yeah, you will do. I know you will do amazing in your LabMed formative and then exams. All right. So we'll start straight on with the inflammatory bowel disease. It is a content that is covered a lot in the GI pathology in LabMed. Now, when do you think about inflammatory bowel disease in questions? You will see things such as chronic diarrhea, bloating, abdominal pain. Now, the main two differentials for those are IBS, inflammatory bowel syndrome, or IBD, inflammatory bowel disease. In LabMed, more likely IBD, just because IBS is not really covered too much. However, you still want some tests to show that, and in actual practice, it is more likely to be IBS rather than inflammatory condition. Now, how you are going to do that? You are going to do some tests, and primarily you will send the stool to check for blood, so the fit test. You will see raised fecal calprotectin indicating colonic inflammation, and also the systemic features are pointing towards IBD or other more serious disease, which we'll come on to later. So things such as weight loss, fever, feeling generally unwell. Now the two main diseases in this category are Crohn's disease and ulcerative colitis. This presentation is actually shared between the two. However, there are differences between them, as you will know, and also there is an overlap, in the investigations. However, when you look at them under a microscope or on sections, they are actually quite different. Now, Crohn's disease, the differences in presentation, yeah, abdominal pain, diarrhea, that's relatively expected. However, it will can present with perianal disease, so anal fissures, abscesses, fistulae, those are quite specific to Crohn's disease and not seen in ulcerative colitis. So fissures, cracks, abscesses, pockets of pus, not nice. Fistulae, abnormal connections between cavities, again, not nice. You can see vomiting and dysphagia if the disease is in the upper GI tract. And in general, it's a mixture of the upper GI symptoms and lower GI disease signs. Now, it primarily affects the colon and in particular terminal ileum, so it will be more colonic signs. However, upper GI signs are indeed present. Now, systemically, the patient may be unwell with fever, weight loss, and anemia. Characteristically, there may be presence of a rash, known as erythema nodosum, so red, raised areas. Now, looking at the pathology, the Crohn's disease will present with skip lesions. It is a patchy disease, it is not continuous, so it will be a patch there, anywhere in the GI tract, from mouth to anus, but in patches. Similar with that is the cobblestone appearance, which again you have areas of inflammation interspersed with areas of normal tissue. And as I've said, most commonly is the terminal ileum, and right after that, the rest of the colon. As we've mentioned, there are fistulae and strictures, and those can be quite significant in terms of morbidity. There are ulcers, in particular aphthous ulcers in the mouth, which compared to the ones which your teeth can cause, just, injuries, they will be present, they will be quite large, and they will also be present away from the hard surfaces such as your teeth, so not caused by trauma. Important question that they like to ask, inflammation in Crohn's is transmural, so it covers the entire thickness of the colon, which is an important differentiator. And as I've mentioned, it is a granulomatous inflammation. As you can see here, this is the non-caseating granuloma, which will be common in the histology slides from Crohn's disease. Now, ulcerative colitis again presents similarly, but it is different. Typically presents in a young person, roughly our age, maybe a bit younger. It is less common in smokers, so it's one of the very few diseases in which smoking is actually protective, and stopping smoking can either trigger first presentation or cause a flare-up of a previously well-controlled disease. For the first presentation in particular, you see will be quite sudden onset, severe, oftentimes quite disruptive disease with bloody diarrhea with rectal mucus. There will be abdominal pain, and we will come back to it, but it is associated with primary sclerosing cholangitis, mentioning it because they love this question in LabMed. Now, you see histopathology. As you will see, in terms of it spreads from rectum proximally or from rectum up, and it is limited to the colon, maybe to terminal ileum, but usually it stops within the colon. And as you can see, there is a continuous disease, and then there is a sharp cutoff, after which you have normal colonic mucosa. As you can see here, the affected mucosa tends to be red and granular. It does look angry. It looks much angrier than the cobblestone we've seen in the Crohn's. And as you can see on histology, the inflammation is superficial. The deeper layers seem fine, maybe a bit distortion of the crypts, but it is the surface. As you can see, there are ulcers, there is inflammation here on the surface, and it just looks a mess. Now, how would you investigate? There are a few different things you will do. There will be raised inflammatory markers in the blood, so the CRP may be high, ESR may be high. The fecal calprotectin is usually high, unless it's a very mild disease. Then you will have anemia, again, blood in stool, you're losing blood. In Crohn's, you can have low limited absorption depending on which areas are affected, so you may get deficiencies. Now, the gold standard diagnosis is the colonoscopy with biopsy of the affected areas. What you will see on colonoscopy, just from the camera, you will see skip lesions with cobblestone appearance in Crohn's and continuous disease with clear cutoff in ulcerative colitis. Now, one side note to that, if the patient has severe colitis, which is borderline on the toxic megacolon, but generally severe colitis, you don't want to go in with a colonoscopy because you are risking perforation and abdominal sepsis. Not nice. So you would do flexible sigmoidoscopy instead. Now the complications. This is the this is the thing everybody fears. This is the toxic megacolon, more common with UC, with that rapid onset, severe first presentation. And as you can see on X-ray, on abdominal X-ray, we see smooth surface of the colon with dilatation. And this risks, again, perforation and sepsis. Now, in Crohn's, we can see strictures. Uh, yeah, this we can see strictures. We can see bowel obstruction potentially. Again, fistulae and abscesses. And important thing to note, both ulcerative colitis and Crohn's disease are a risk factor for colorectal carcinoma. Now, in terms of extraintestinal disease, so what things happen outside of the colon? What you can see is sometimes in ulcerative colitis is a risk factor for PSC, and they like asking questions about that. In Crohn's, you can see the aphthous ulcer in the mouth. You can see erythema nodosum, those funky red areas on the skin, and pyoderma gangrenosum, which are essentially ulcers filled with pus, uh, which again happen in Crohn's. Now, treatment, you don't really need to know much about treatment, um, but what you can see, so it is treated corticosteroids, acute flares, some immunosuppression, non-steroidal, like mesalazine, or disease-modifying drugs like azathioprine and methotrexate to control the disease, and you can use anti-TNF agents, and actually they are used more often this today. In terms of surgery, and apologies for that. In terms of surgery, um, you may need emergency subtotal colectomy in UC, for example, if the risk is of toxic megacolon. And it can be used as elective as well for severe or refractory disease. One question which we may get asked is about ulcerative colitis. Because it is limited to the colon, the disease can be cured with just cutting out the colon, and that's it. However, in Crohn's, the disease affects the entire GI, and good luck to anyone who wants to cut out the entire GI tract. However, it can still be used in Crohn's to cut out the areas which are not responding to medical treatment, in particular strictures or particularly annoying fistulas. Right, let's go to the Socrative. Let's see whether I can. Uh, Apologies for that. There we go. Let me know whether you can see the questions. I see two students currently in the Socrative. In case anybody has any troubles, I've put on the QR code as well. And this is a difficult question. It's more difficult than what you would get in LabMed, so just try your best. In case you have troubles, you have the QR code in here as well. Let me know in the chat if you have any issues. Okay. Okay, I have two students out of two answered. Anybody wants to join but has trouble joining? The room name is Osmi. I will put out the QR code in here as well. But if I don't get any updates in, if, let's say, 15 seconds, we will just talk through the answers. And again, the next questions will be a bit easier. That was just to get your brains moving. And of note, for all of the questions, try to think of the answer that fits the best. The life about medicine is that unknowingly not always all of the features match. Mm. All right. Shall we go to the answers? And if other people want to join later, that's fine as well. Okay, yeah, that's actually a really good set of answers. Now, in terms of the one answer that is wrong, I don't blame you whatsoever. If you just, let's just have a quick look at the question. So this person has, yep, features consistent with IBD. So frequent small volume stools, blood and mucus. There is sensation of incomplete evacuation. Now, however, one of the things which kind of points towards UC compared to the Crohn's is in terms of the anal involvement. There are no masses, fissures, fistulas, or skin tags, which is what we would expect in Crohn's. Also, another thing which points towards UC is this one sentence which is easy to miss, which is she smoked 1 pack of cigarettes daily for 8 years and quit 4 months ago. And interesting thing is that smoking is protective in ulcerative colitis. If you stop smoking, there is a risk of either having first episode or relapse of ulcerative colitis. However, with Crohn's, it's actually the opposite. So smoking worsens your Crohn's and stopping smoking makes it better, which is quite an interesting conundrum given how similar those diseases present, but probably not surprising given the fact that they have two different types of histopathology. So thank you so much to everyone who answered. We will go back to the presentation. Hopefully you can still see it. Now, the big bad boy, the biliary tree. No need to answer, but when I first seen those, I was a bit confused because cole blah blah blah. Now we will walk through it, how to differentiate, and hopefully by the end of today, hopefully now, but even by the end of today, you will feel much more confident. Now I will take you on a journey. This is a journey of the gallstone. So the gallstones typically form in the gallbladder, with the bile just sitting there and things having the chance to just crash out of the bile. And if you have stones in your gallbladder, it's known as coli, so it is your gallbladder, and lithiasis, which means stones. They can be present there, they can be very much asymptomatic. If the gallbladder contracts, for example, if you eat a fatty meal and the bile needs to come out, it can contract against those stones, causing biliary colic. Now, when the bile is being pushed out, a small stone can be taken up and it can block the cystic duct. Now the gallbladder is not going to be happy with it, and because it cannot empty anymore, we can see cholecystitis. So the inflammation of the cholecyst or the gallbladder. Now, because there is inflammation, again, there is still that right upper quadrant pain, typical for pretty much all of the conditions. However, we will also see inflammation, which is the fever, raised white blood cells, raised CRP. Now, going further down, the bile can lodge in the common bile duct. If there is still some flow, typically it won't cause too much inflammation. However, there will be back pressure on the liver, the bile won't be able to come out, so it will stay behind. It will cause the jaundice, the liver won't be super happy, so there will be, in particular, raised alkaline phosphatase, a bit of raised other LFTs as well, but to a lesser degree. However, there is no inflammation, so no fever, no white blood cells, no CRP. Now, finally, if there is complete blockage in the common bile duct part of the or in ampulla of Vader, now the entire thing gets inflamed. We get the Charcot's triad. So we have right upper quadrant pain because we are doing something bad to the biliary tree. We will get inflammation, so fever of the Charcot triad, raised CRP, raised white blood cells. And finally, we will get jaundice or raised bilirubin because it is not draining from the biliary tree. Okay. Yep. And Raynaud's pentout is essentially the symptoms of severe cholangitis, but I will talk it through you in a second. Now, this is a big chart if you want to go into specifics. It kind of talks you everything about what we will cover, but to simplify, if something has itis, there is inflammation, so fever, CRP, white blood cells. Whereas jaundice means that the bile is not draining from the liver, so whatever is happening has to be happening in the common bile duct or in the ampulla of Vater. Now, a quick explanation. Gallstones. Common, common, common. We will probably get them at some point in our lives, at least vast majority of us. Now, the key risk factors is, again, not politically correct, fat female 40. So, obese woman in her middle age. And this typically will be cholesterol stones, which are most common unless you have other risk factors. It can be triggered by rapid weight loss. So our obese woman decided to lose some weight. And now her gallstones have gotten worse. How unfortunate. And there are a few other risk factors. Now, sometimes they like to ask about pigment stones, which are due to high levels of bilirubin, and these are associated with things such as chronic hemolysis. Now, most stones are asymptomatic actually, so they can be incidental findings on other examinations. But as we've discussed, biliary colic, cholecystitis, and everything we've already discussed. By the way, ask me any questions either via chat or just shout if you want me to go through anything, explain anything a bit more. Biliary colic, colicky abdominal pain, right upper quadrant. Worse after eating, especially fatty meals. You have your obstruction of gallbladder neck or cystic duct, or just the gallbladder contracting against the stone. Murphy's sign, you press in the right upper quadrant, ask the patient to inhale. If there is a sharp catch, hurts more. Investigations, you want to differentiate from cholecystitis and from cholangitis. So you will do CRP and ESR to check is there inflammation, and bilirubin to check is the bile duct blocked. The investigation of choice is ultrasound, and you will see stones with a shadow behind the stones. Unfortunately, the CT is actually useless for cholesterol stones, so the most common ones, because there is no metal in them, no calcium. So the X-rays just don't get absorbed. They are invisible to X-rays, including CT. Cholecystitis, things are getting more spicy. We get inflammation. So very similar, but now the gallbladder is inflamed, the patient is more unwell, and we get, in addition to what we've seen in biliary colic, the pain is likely a bit more constant, still colicky, but doesn't resolve between contractions. And we have features on inflammation, so the high white blood cells, and also on investigation, fever. Ultrasound scan will again show you the stones, and to manage, just cut out the gallbladder at this point. If it's extreme, you can go in hot and just cut it out right and there, or you can do it as an elective if the inflammation currently is not bad. Now, cholangitis is something you don't want to miss. It is the inflammation of the biliary tree, typically due to the blockage of the common bile duct. So we will have bacteria spreading from the gut to the intrahepatic ducts. Not nice. And the Charcot's triad. Remember the Charcot's triad because that's your key differentiator. Again, you have right upper quadrant pain, you have fever, but now you get jaundice. And this together gives you cholangitis. And as it says, cholangitis can easily convert into biliary sepsis. So check in the question, is the patient hypotensive? Is there a high heart rate? Is the resp rate high? If so, think sepsis, do sepsis 6. If they are a bit less unwell, you will do standard bloods, but you will also do MRCP to locate the stone, as the ultrasound does not image the entire biliary tree, and you want to see the entire thing. In terms of management, resuscitate, antibiotics, and ERCP is your previously investigation, but now you will go in and fish out that gallstone. Now this table is the simplified version of the other table, and this one do commit to memory for your LabMed exams. Okay, let's do another Socrative. Hopefully it should be appearing on your devices. Again, please do scan the QR code and join if you haven't joined already. Now we have a few more people. Again, there is a QR code or enter the room name Osmi. And please try to tackle this question, which is a little bit easier than the previous one. Or at least I hope so. Okay, thank you so much to the another person who joined. The Socrative. Let's wait for a little bit longer. Ideally, let's get another answer and we will have a look at the answers. All right, let's have a look. Okay, there is actually an interesting spread, and I see that most people went for ascending cholangitis. So let's walk through it. Now, what do we have? We have a 25-year-old Ghanaian man presenting to A&D with persistent upper right quadrant abdominal pain. And let's think ascending cholangitis first. We have our three criteria of ascending cholangitis. So we have our right upper quadrant pain. That's criterion number one. Then we have our second criterion, which is fever. And does anybody see fever? I cannot see any fever. And that's kind of what gives this question away, which I know we see mild hyperbilirubinemia. So we are thinking that there is some jaundice going on. Now, this question is again a bit cheeky, but what you can, I guess what gives it away is there are a few things which are not exactly explained in this question. So you have occasional severe pain in his limbs, especially after exercise, which makes you think, that doesn't really fit. And then there is anemia, increased reticulocytes, which anemia with diuretics. There are a few different causes, but you are starting to think maybe hemolysis. And essentially the complication of Ghanaian man, occasional severe pain in his limbs after exercise, anemia with lysis. It's likely a sickle cell disease. And sickle cell disease releases a lot of hemoglobin into the blood, a lot of bilirubin. So this is actually pigment gallstones as a complication of a sickle cell. So this is one of the more difficult questions, but a realistic one this time for LabMed, where you have, I'd say, three layers in the difficulty. As for the pancreatitis, mm, the pain would typically be more central, radiating to the back. Um, and again, it wouldn't explain this part of the question. If unless anybody has any questions regarding this question, are we happy to proceed? I'm going to say yes. Lovely. But please do shout. And here we go. Pancreatitis. Now, pancreatitis. There is an element of enzyme dysregulation and autodigestion. As they say in Grey's Anatomy, I think, don't fuck with pancreas, and they mean it. You poke it wrong, and it releases enzymes. What those enzymes are? Digestive enzymes. And it starts digesting itself. And you have a whole load of trouble onto your hands. The patients tend to be very sick, they deteriorate rapidly, and as we've just said, they present with severe epigastric pain. It tends to radiate to the back. There is nausea and vomiting. There is guarding, so they are peritonitic. There may be loss of bowel sounds as inflammation just makes the bowel say, nah, I'm quitting and stop working, aka ileus. And the characteristic thing is the Cullen's sign, so the bruising around the umbilicus, or the Gray-Turner sign, or the bruising around the flanks. If the question says about those, you can be quite certain it's pancreatitis. In chronic, it's a side note as it doesn't really come up with exams that often, but if people have many bouts of acute pancreatitis, they may be alcoholic, have gallstones for God knows how long, the inflammation of the pancreas may become more chronic, and there, you will see it as calcification on the CT scan. This may lead actually to the patient needing enzyme replacement therapy, also known as CREON, for the rest of their lives. Now, I get smashed. Everybody loves the mnemonic. I don't think I've ever committed to memory the entire thing at once. Kudos to everyone who can, which is important to think what is the most important bits of that. Gallstones and alcohol. If you see pancreatitis on the words, the chances are either one of those or both will be your answer. Also, it may be idiopathic, also known as God knows what. And of course, if you see other things, it's important to note there is one question on PassMed about scorpion stings. If you find it, it is absolutely joyful to be able to finally use that bit of knowledge in your heads. But that's probably only time you will ever use it. Investigations are important in pancreatitis. Now, the serum amylase and lipase will be raised in pancreatitis, and to be diagnostic, they need to be 3 times above the upper limit or more. So if they are just kind of just bobbing slightly above, it's not going to cut it. It's not a diagnosis of pancreatitis. There will be raised inflammatory markers. Blood glucose can go out of whack because in the pancreas you also have your pancreatic islets which control that. The management, it's supportive. You want pain relief, fluids, oxygen, antibiotics, and just wait for the storm. If there is a clear cause you can identify, such as a stone that is sitting in an ampoule of butter, fish it out with ERCP, but apart from that, just wait until things settle down. Now, I've been asked to cover this, a bit of microbiology, which is diarrhea and gastroenteritis, aka something we probably all have experienced at some point. Not nice, and you will come across it as you're being a doctor's. So, most common cause will be viral. In kids, in particular young ones, there is the rotavirus. However, there is a vaccine so that is decreasing in incidence. We also have the noro or the norovirus. As you can see, you 100% don't want it. It's nasty. It causes outbreaks in hospitals. So if your entire bay, if the nurses cannot keep up with changing the sheets in the entire bay, it's probably noro. Diagnose with stool PCR and just keep them hydrated until they recover. Now, bacterial causes of food poisoning, it's important as they do ask about that. You have your preformed toxins. These are gram-positive bacteria, your Staph aureus, Bacillus cereus, and Clostridium botulinum as well, but primarily those two. How to differentiate these two categories? The preformed toxins have fast rate of onset, roughly 6 to 8 hours post eating something dodgy, whereas the other ones will typically start to develop 24 hours or longer after you've eaten the culprit. Now you have cholera with the rice water stool. That's your nugget of knowledge to commit. You have Campylobacter, undercooked chicken or other meats. Shigella, so exotics, bloody diarrhea. Salmonella, quite similar. You have E. coli, and again you can do stool PCR plus minus culture. Of note, which will come across in neurology, if you have diarrheal illness, which may even be mild, and then you develop neurological symptoms, think about Guillain-Barré symptoms, syndrome, and Campylobacter. Traveler's diarrhea, you come out, it's Christmas, just finished LabMed, you take a trip to Philippines, you drink tap water, you have bad times coming ahead, my dear friends. Now, E-tech or E. coli is most common, so it's your watery diarrhea, classical traveler's diarrhea. Cholera, we've already discussed. Shigella, we've discussed. And amoeba, uh, you will get again this diarrhea, but then you will get liver LFTs will go off, and there will be right upper quadrant pain, and you will develop a liver abscess. That's your entamoeba histolytica. Giardia is very annoying to treat, so you will go somewhere exotic, and you will come back with this bloating that just kind of dragging for weeks on end, some diarrhea, but not much. You diagnose it with wet prep, and it says treat with metronidazole. You try with metronidazole, and then you get creative because it's resistant to a lot of things. So you may be stuck with your local friendly ID until they. I remember sitting in one of the clinics and just scratching our heads. What are we going to do now? Typhoid, we'll come back to it in ID lecture, but Salmonella typhi, Southeast Asia in particular. Uh, and interesting thing is it starts with constipation, not diarrhea. You may get rash, abdominal pain, and it's significant because it can cause perforation. So we need to monitor for that. And the weird and wonderful, the EHEC or enterohemorrhagic, it infects your gut, and then it starts wreaking havoc. As the name suggests, it's hemolytic uremic syndrome. So hemolytic, you get hemolytic anemia, and uremic, you get the renal failure. And in C. diff, it's the overzealous DGH that's throwing piptas at everything, and you get essentially very bad diarrhea with risk of pseudomembranous colitis. You will do the PCR, typically for toxin and the bacteria themselves, and the risk are again of toxic megacolon and perforation. And again, it's just a summary of everything I've just said, so I will leave it to you in the slides afterwards. Who's up for some more Socratives? We'll try to go faster this time around. So, hopefully you can see the Socrative. Have a go at this question. Okay, we have one answer, two answers. Remember, it's just a Socrative. I'm not going to judge. There we go, three answers. Amazing. And a nice spread of answers. Again, let's talk through it a little bit more. So, in terms of the two answers which were not correct, we have some Shigella, and I'm going to say unlikely because I see, yeah, there is a diarrheal disease, but it's a mild watery diarrhea. With Shigella, you expect essentially dysentery, so severe diarrhea with blood in it, which means like it doesn't sound nearly severe enough. Now going with the cholera, again kind of mild watery diarrhea, it doesn't really cut it. You are looking for this rice water stool, and literally, if you want to see what diarrhea in cholera looks like, just go to your kitchen, cook some rice. The water that is left over is what's coming out of people's rear ends. Not nice, very dangerous. And the Giardia is the correct answer. Now, why? We see that mild kind of bopping diarrhea. He drank water from the mountain streams, which I should have mentioned is a risk factor. He is afebrile, so generally quite well. Nothing that would be kind of making you go, he doesn't look too good. His stool is negative for occult blood, so again, just kind of nailing home that it's not Shigella. There is no blood in there. And it abates in 3 weeks. Um, so again, it's one of those diseases that just kind of popping up and down, non-specific. In terms of other answers, rotavirus wouldn't last for 3 weeks. It would last for a few days, and it's typically the disease of children, which you correctly identified. And Staph aureus, you would be thinking more under or rather reheated food. And again, it would be flash, quite rapid onset, 6 to 8 hours after eating something dodgy. But hopefully that explains things a bit. Now, question number 4, which will lead us to the next section. How about you throw me in some responses on what is going on with this guy? Now I'm going to give you some questions before we go into the section. We have one. Let's take one or two more, and then I will just crack on. If at any point you decide you have enough Socratives, let me know and we'll just crack on through the slides. Okay. Congrats. Yep, those are two very likely things that are going on. So yeah, pain on swallowing, male obese smoker, all of the risk factors for GERD. The pain on swallowing may be pointing you a bit more towards something has already happened in the esophagus, but again, it's not specific. And the long history of acid reflux and heartburn are pointing you again towards Barrett's, but GERD is definitely there. So I'm going to take both answers as correct. Right. We are going with Barrett's. Now, somebody has GERD for a very long time. Initially, their esophagus looks like that. Hopefully, all of ours look like that. Now, there is something bad happening there. You can see that there is this red mucosa that is kind of escaping the stomach, and I don't want to say migrating because it's not walking on its legs, but it is expanding from the stomach. Now, may you ask questions about what is happening in Barrett's? So it's metaplasia. We are changing one type of cells into another. So we are changing from the squamous epithelium, which is what's supposed to be in the esophagus, to the columnar epithelium, which is what's in the stomach. And it's a big risk factor for developing neoplasia, which leads to the cells transforming into malignant cells and esophageal cancer. Now, the main risk factors for GERD and Barrett's: male, older middle age, white, obese, smoking, and family history. Now, how is it diagnosed? Again, the gold standard is OGD or gastroscopy. Come in with a camera and see it. You have your pink velvety mucosa. Now, keen-eyed of you may notice that there is danger brewing. And indeed, there is big danger brewing, which leads us to the next slide, the esophageal cancer. You will see a mass or ulceration in the esophagus. Now, the question will ask you, okay, so which one is it? You won't panic. You will remember two things. In the lower third, it's the more common, and it's lower, it's close to the stomach. Stomach is secreting, so those are secreting cells. It's your adenocarcinoma from the transformed Barrett's. And because it's adenocarcinoma, you have features of adenocarcinoma, quick revision, glands, and mucin, and cuboidal and columnar cells. The key risk factors: untreated GORD, and in particular Barrett's esophagus. Now, squamous cell carcinoma is more rare. It happens in the upper two-thirds, so no secretion from the stomach, it stays squamous. Now we have our squamous cells, so keratin, flat cells, and primitive basal cells, and it can develop into ulcers. Now the key risk factor for the squamous cell carcinoma are smoking, number one, and drinking alcohol, number two, but of note, together they are synergistic, so the risk of doing both of those things is higher than the sum of the individual. However, there are more rare risk factors, but the key things are to investigate, you will do OGD and biopsy. Similar with the cancer of the colon, if you want to diagnose, you want to see it. Pop the camera in, see it, take a bite, send it to your friendly histopathologist, who will give you the answer. Socrates 5. There we go. Another question in preparation for the next slide. 40-year-old male businessman just returned from holiday in Thailand. Feeling exotic today. There is some nausea. He is jaundiced. The liver is large. Albumin is still normal. ALT and AST are through the roof. His bilirubin is pretty much off the charts. What is the most likely thing that's going on? And if you want to see how jaundiced, essentially radioactive yellow. And I have seen a patient that was radioactive yellow. So maybe you will see as well. Hmm? One brave soul, two, and three. Let's go. Great. Now, in terms of the question, hepatitis A versus hepatitis B, both are very good shouts. And to be honest, both are possible. But again, the question is most likely. In terms of the cause of acute hepatitis, which is what we'll see in kind of the holiday in Thailand, the hepatitis A from eating or drinking something dodgy is more likely. Now, I know businessman in Thailand is used in PASMED as a man making questionable choices, but let's try to keep most likely and most reasonable. Let's not assume that every 40-year-old going to Thailand is going there for services. Okay, LFTs. Now, LFTs are quite important to tell you what is going on. Now, they say it's function, it's rubbish, it's not function. It's the test of damage. What is currently being damaged? ALT and AST are markers of the damage more directly of the liver itself. So if they are sky high, the cells of the liver are either dying or not happy. ALP or ALK-Phos is expressed in the biliary tree. So if the damage is happening to the biliary ducts, this one will be sky high. The problem is oftentimes both of them are elevated. So what I advise you to do is to cut the upper norm and see, is the ALT and AST more elevated out of proportion, or is it ALK-Phos that's more elevated out of proportion? If it's ALK-Phos, It's the biliary ducts that are suffering. If it's ALT and AST, it's the liver directly that's suffering. Such as in our gentleman with hepatitis A, his ALT and AST are sky high, whereas his alphos would likely be elevated, but not in the thousands. Albumin and total protein are more actually the function of the liver. If they are low, the liver is not doing very well. It's not managing to do what is required of it. Similar with bilirubin, it may be high. It will indicate either the liver is damaged and unable to process it. However, note, it can also mean that the bile ducts are blocked and it's unable to get rid of it. And again, it's a summary diagram to study in your own time. Who wants a Socrative? I'm trying to think whether there is a slide about what's going on. Just to make sure, I will give you a quick explanation afterwards. And how are we doing on time? We still have half an hour. I think we should be able to make it in time. If not, feel free to send me a formal complaint. Okay. Will we get answer number 3 or maybe answer number 4? But if not, oh no, I've just checked. Yep, yep. Let's have a look. Okay. So yeah, we have question of what is going on. And as most people have answered correctly, that there is infection with H. pylori. So why is it? We have persistent nausea for 5 years with occasional vomiting, which is quite a common presentation in H. pylori. No abnormal findings on examination. Uh, Upper GI endoscopy and a small area of gastric fundal mucosa has loss of fragal folds. Biopsy shows abnormal columnar cells, nuclear atypia, mucin secretion, so that's your adenocarcinoma. And upper GI shows pattern of gastritis with chronic inflammation. Now, H. pylori is what will give you that. Chronic alcohol excess is a risk factor for this presentation. However, there is no history of alcohol abuse in the question. And also, why would it be just for 5 years? It just doesn't. They would either tell you that the person is drinking so and so, or you would see it just doesn't fully explain. But I appreciate that it is that chronic alcohol excess is a risk factor for stomach cancer. But as many people have answered, H. pylori infection is the biggest risk factor for stomach ulcers, number one, and subsequently stomach cancers. Right, we will come back to the hepatitis. Now, acute hepatitis is when you get that fulminant, the liver is unhappy. It is being damaged acutely. LFTs, especially ALT and AST, are sky high. Bilirubin is sky high. The patient comes in just with that fluorescent yellow look. It is primarily caused by hepatitis A and E. In adults, hepatitis B can cause it, which is why I would say hepatitis B could be the presentation in this man, but A and E would be the more likely cause of the presentation in our guy. It can also be caused by CMV and EBV. The chronic hepatitis is when the infection is chronic, it's rumbling, it's slowly destroying the liver is repairing itself, but again it just continues because the body couldn't clear it. Now hepatitis C will typically cause chronic hepatitis. Hepatitis B can also cause that. In particular, if you are a kid that's infected with Hep B, you will likely develop chronic hepatitis. Hepatitis D can co-infect with B and make it worse. And hepatitis E, in rare cases, in immunocompromised people, can also become chronic, but it's very rare, and it's better to just think about it as acute unless the question is really pushing you towards it. Now, serology. LabMed likes to ask you about Hep B serology because it's confusing. So, you are a med student. You have just pricked yourself with the needle from your cirrhotic patient with Hep B, and you are not happy about that. What blood test will they do? Now, they will do hepatitis B antigen, which will essentially the surface antigen. It's present in two places. So, sorry, back to square one. If you have hepatitis B surface antigen circulating in your blood, this means that you are currently infected with Hep B, and there is no ifs and buts about it. If it's early post-infection, it may be acute disease. However, if it persists for more than 6 months, you have lost the lottery and you have become infected chronically. Now, the antibodies is your differentiator. If somebody has antibodies against hepatitis B surface antigen or HBs antibody, that means that they are immune to the virus. They have either been exposed in the past and cleared the virus, or they have been given the vaccine. Interestingly, it's negative in chronic disease. How you can think about it is, if you haven't developed antibody to the surface antigen, well, you are not going to be immune. If you would have developed it, you would have cleared the virus. Now, the question is, how do you differentiate somebody who's been vaccinated from somebody who had the hepatitis B and cleared it? That's where your core antibody comes in. If somebody has immunity to the core, this implies previous or current infection. Why? Because the core antigen is not part of the hepatitis B vaccine. So if they have seen... Oh yeah, no worries, Maddie. Email us later on if you want the slides. But yeah, it was lovely to have you. But yeah, if there is the core antibody, somebody had the virus in the past, and the IgG will persist long term. HBe antigen, you may be asked about it, but less likely. Essentially, if somebody is infected and they have the E antigen as well, this means that they are currently infectious and their viral load is likely high. Alright, so make your life easy. These are your scenarios. Resolve previous infection. Their antigen is negative because they don't have the virus at the moment. Their core antibody is positive because they have seen the virus. And their surface antibody is positive because they developed immunity, they cleared the infection. Active infection. Their antigen is positive because they have virus circulating in their blood. Their antibody is positive because they have seen the virus. And their HBs surface antibody is negative because they haven't managed to develop immunity to the virus. Question is it acute or chronic? Check your core antibody. If it's IgM, it's likely that it's a very recent infection. If it's IgG, it's more likely to be a chronic infection that persisted. And somebody that's vaccinated, there will be negative for antigen because They are immune, so there is no virus in their blood. Their core antibody will be negative because they haven't seen the virus. They haven't seen the core. It's not part of the vaccine. And the surface antibodies are positive. That's what's actually keeping them protected from the virus. And now there are many different causes of non-viral liver disease. Remember about the alcoholic liver disease and MASLD, or the metabolic associated, also known as the non-alcoholic fatty liver disease. Alcoholic liver disease, self-explanatory. Keep to your limits. Non-alcoholic fatty liver disease, not associated with alcohol, but with metabolic syndrome. So somebody that's obese, has high cholesterol, high triglycerides, uh, their liver initially becomes steatosed or filled with fat, and then it progresses to fibrosis. Now, those questions do get asked in the formative, but I'm not going to cover them today unless you raise your hand right now and ask me to cover them. Feel free to ask about them later if you need further explanation. We will cover PBC and PSC and autoimmune hepatitis in few slides. However, the key thing about all liver disease, both viral and non-viral, the end stage causes cirrhosis. So you have your lobules of liver separated by strands of fibrous tissue, which you can see on magnification. It's no longer your smooth surface. It's nodular, it's grainy, it's hard, and the key risk factor is if you have cirrhosis, you are now at risk of liver cancer or hepatocellular carcinoma. If there is no cirrhosis, it's very rare to develop HCC. PBC, and we will talk about the autoimmune cholangitis and how to differentiate them. Primary biliary means it's as direct as you will get. So it's autoimmune, it shows up with pruritus, so intense itching. That's the symptom of bilirubin circulating in your blood. Not nice. And jaundice, again, because the bile ducts are getting blocked. Alk phos will be elevated more highly than ALT and AST because the ducts are getting blocked. And it can progress to cirrhosis and liver failure. The key thing that differentiates the PBC from PSC is they will be positive for anti-mitochondrial antibodies. And they like that in your LabMed formative. And that's PBC histology. So inflammation, granulomas, cholestasis, fibrosis. Nothing to ring home about. PSC is interesting. They like it because, how should we say it? Sclerosing, it's not as simple as biliary. Now, what are the things which kind of tell you it's PSC? It's either the patient has features or is diagnosed with ulcerative colitis because it's a significant risk factor. It can also progress to cholangiocarcinoma, so beware of that. They may ask you what they are at risk of with PSC, cholangiocarcinoma. It can be asymptomatic, again, may have pruritus jaundice. Again, the alk phos will be raised first and higher than the other LFTs. In terms of antibodies, it will be positive for P-ANCA. However, as you will remember, P-ANCA is not specific, so it strengthens your diagnosis, but doesn't prove it directly. And if you do imaging, so ERCP or MRCP, you see this beaded appearance. It's no longer a nice, smooth tree, but it's beaded like beads on a string. And another thing why they like it is the food eponym. The onion skin fibrosis means PSC until proven otherwise. I guess it's histology, it just means PSC. And this is a summary table with a bit more detail, but hopefully it is consistent with what I have just said. Autoimmune hepatitis, again, it's autoimmune, so it's more common in females. They will likely have other autoimmune disease, In this case, the liver is getting attacked directly, so the ALT and AST will be higher compared to ALK-Phos. And another thing which is more specific that will kind of help you to nail down the diagnosis is smooth muscle antibodies. Why smooth muscle antibodies in the liver? I wish I knew, but that's what it is. And now I have just a set of final Socrative questions. I have one more slide, but we'll just go through as many as we are able. Da, da, da. Question 7. 35-year-old healthy woman develops sudden severe abdominal pain. On physical examination, she is afebrile. There is pain centered in the mild epigastric region, though there is marked diffuse tenderness in all quadrants. Bowel sounds are absent. No mass is palpable. Lab studies show serum lipase is 610. Which of the following lab findings is most likely to be the risk factor for her illness? Given you probably know the diagnosis, you can see that I removed the two most common ones because I know you're Oxford students. You can do this. Or you may have fallen asleep and gotten tired of listening to me talking, which is, to be honest, also very valid. Okay, there we go. We have one answer. Let's whiz through those questions. Let's see. Okay, now that's a very important misconception, so I'm happy we have captured it. Uh, so hypercalcemia is one of the risk factors of I get smashed. Now, hypercholesterolemia is a bit of a red herring because it's the high triglycerides, so your fats, not cholesterol, that elevate your risk factor for pancreatitis, and cholesterol is actually not a risk factor. Now, if you go into PASMED, the calcium is the annoying little bitch of pancreatitis. Why? High calcium is a risk factor for getting pancreatitis. However, low calcium means that your pancreatitis is going to be severe. I know I did not make the biology for that, but it's important to remember that high cholesterol is not a risk factor for pancreatitis. But now you will know for your formative and for the exam at the end. Another thing which is important to remember, now lipase is a binary switch as well as amylase. If it's above the threshold, this means you have pancreatitis. However, regardless whether it's 600 or 6000, it does not mean how severe your pancreatitis is. That's another nugget of knowledge to remember. Question 8. 20-year-old man. Um, Probably as about as, maybe not as, just slightly younger than us, isn't it? Healthy, but family history of colon cancer with onset at a young age. No abnormal physical examination findings. He undergoes colonoscopy with over 200 tubular adenomas ranging in size from zero point 0.2 to 1 centimeter on gross inspection and microscopic examination of biopsies. Uh, what genetic disease is he most likely to have? He's clearly going for a record. Maybe not in size. The size is respectable, but not huge. But 200. Okay, it seems to lag on my screen. Thank you. It actually helps. But yeah, it's adenomatous polyposis coli is a very good answer. Now, multiple endocrine neoplasia is something you will have to remember for your exams because they like asking questions about it. But colon cancers is not part of men. Uh, I hope that your tutor who will be doing the endocrine lecture will cover the syndromes in details. But the colon is not part of them. Now, coming very quickly to the presentation, this is the summary of the two main syndromes. Most of you identified that this chap has FAP, or the familiar adenomatous polyposis, and as characterized, it is hundreds and hundreds of polyps in our age, and if untreated, he will get cancer. How do you treat it? Just cut out the colon because there's nothing else you can do. Now with Lynch syndrome or hereditary non-polyposis colorectal cancer, you get it's a bit more common compared to FAP, and typically there is just a few polyps. But the problem is those few polyps are much more likely to progress to cancer compared to a person that is otherwise healthy. Because of that, the age of kind of developing your cancer is a bit older. And also you can, although you still have very high chance of colon cancer, you can manage it a bit more conservatively with frequent colonoscopies and cutting out anything that's suspicious, rather than just getting rid of the entire colon. Okay, and how many minutes, how much time do we have? We have 10 more minutes, 9. Let's try to do this question and then we will just switch to the end. So, 9-month history of intermittent foul-smelling bulky stools, abdo-bloating, excessive flatulence, unintentional 7 kg weight loss. Something's not right. There is no fever, no symptoms, no blood in stool, hematochezia, no melena, no recent travel, no antibiotics. She has fatigue, despite adhering to the ferrous sulfate supplementation for her iron deficiency anemia. She has autoimmune hypothyroidism, and her older sister has type 1 diabetes mellitus. Now, you have to think what is your diagnosis? That's step number 1 in the questions in clinical school. And step number 2, what is the answer to the question they are asking, which is what other manifestation of her disease she's likely to have. I'm going to risk it in a like 15 seconds or so and say that people have answered. And hopefully I haven't, insulted you too much by thinking, oh, people aren't answering. Thank you so much for everybody who does. There we go. Interesting spread. Let's go through everything in question. Now, this is the condition we haven't covered, but I think is important because it does happen both in AKTs and in LabMed. Now, what are we thinking? Intermittent, foul-smelling, bulky stools. Seems interesting with bloating. Could be IBD. Unintentional 7 kg weight loss. That points us towards something more serious than simple IBS. That's right. There is no fever though. No nocturnal symptoms. No melena. So there is no blood in stool. We're thinking, is it truly IBD? Now, the thing which kind of points you towards the right answer is persistent fatigue despite adhering to ferrous sulfate supplementation for iron deficiency anemia. So she's not absorbing iron. So it's more likely, it's probably Crohn's, we are thinking. which I can see, the pyoderma gangrenosum and aphthous ulcers. You've remembered that those are Crohn's presentation. That's good. However, she has strong autoimmune history, and also this disease is kind of intermittent. We are thinking something's kind of fluctuating. And this is more typical presentation of celiac disease. How would you test it? You would ask her to, you would get a colonoscopy, sorry, OGD, actually, and take a biopsy of the duodenum. And she would present with dermatitis herpetiformis, which is characteristic rash found in celiac disease. I guess the answer, the stool being foul smelling, bulky, and the bloating with flatulence is not exactly your kind of diarrhea with blood and mucus that you see in inflammatory disease. I hope that's somewhat helpful. One thing I could help, what bloods would you do? You would take the bloods for antibodies. And your antibodies would be the anti-tissue transglutaminase, IgA and IgG, and potentially anti-endomysial antibodies as well. However, she would still have to be eating gluten for those to show up. We have last 5 minutes. So, please scan the QR code. If you would like the slides in particular, please leave feedback. We are trying to improve those lectures every year. Let us know if you think that there is something we've missed which you think is relevant to cover. Actually, please feel free to post in the chat or unmute if you'd like me to explain something that I haven't covered or I haven't covered in enough detail. And at the end of the slides, there is also a bit of a summary of what I think are the kind of key bits of knowledge. But yeah, I will leave the slides here for a few more minutes. Feel free, once you have filled out the form, feel free to leave. I will try to send the slides in the coming days. Oh, the summary slide. Yep, absolutely. Yep, so in terms of the summary, Crohn versus UC. Yep. Uh, Crohn versus UC, granulomas, skip lesions. I guess you can read that. It's all of that we've covered. But it will be in the slides that I sent. And yeah, if you have any questions, feel free to ask them now. Email me. Hope that was helpful.
Thank you.
No worries. Okay.